Hello and good afternoon to everybody. Really nice for you to join us today, and I'm really pleased to introduce, because I don't think, Tom, we've not done a webinar before, but you've very kindly been on a number of our clinics and been on our medical panel, so thank you very much, and I'm sure that we've got lots of people have lots of questions for you. As I said, I've got some questions that people have posted, so what we're trying to do is encourage people when they register to post their questions at that time as well. So I've got some already, so we'll go through those at the end as normal. But meanwhile, as we're talking, if anyone has any questions, please do post them. I can't guarantee A, we'll get through them all, or B, that Tom may be able to answer them. But then that's no disrespect to you, Tom. So we'll just see how we go. So first of all, what I'd like to do is, if we kick off, Tom, if you'd like to tell everybody who you are, the role you play, that would be brilliant.
Great. So my name's Tom Mars. I'm one of the consultants at the Evelina Children's Allergies Department. I've been there I've been actually in the department for about 12 years now. I joined when they were running one of the research trials trying to protect young children from developing food allergy. And from there, I became very interested in eczema and the progression of how allergies develop in a lifetime. So my training is all specifically with children, and I don't work with adults because we have to choose at an early stage in the UK which age group we do. But my interest from there has been really much in trying to protect against the development of worsening allergic disease, and that involves both from the skin as well as the food, but also the respiratory allergies and hay fever. All of those can get really quite difficult with children who are severely affected by the allergies as well. So at St Thomas's, I lead two different services. One is specifically looking after the babies and trying to get allergens into their diet to teach their body that it's a food and not an allergen by eating it regularly and trying to get there in time. And then the other main part that I lead is joint with a gastroenterology team doing joint clinics. And we see a wide age groups in that clinic as well.
Okay, so today, I mean, obviously we're, as Tom said, his focus is on children. He is very happy to try to be inclusive, to obviously talk about with adults, but it is very much stressed that this is his expertise is specifically with children, but obviously there's a lot of similarities, or there's some of the same issues. So hopefully it will be inclusive enough for everybody. And I think what's great about Tom is that he's very happy to say if he doesn't know something, then he'll let you know. What is, and I appreciate that when you're training and that you have to make the decision between a child and adults, but is there a very big difference between children and adults when it comes to eczema, allergies and respiratory?
I think it's a fair question. We see a lot of those disorders which are characteristically meant to be more amongst adults. We do still see them in the pediatric age group, but some of the likelihood of how severe they are can be different. So I'll give you an example. Sometimes people develop hay fever so bad that they can't sleep at night, and it affects them not only when they're out and about, but through every waking hour. And that can be both in adults, but also in children as well. And so the treatments start off being very similar. Because we tailor things more to children's care, the easier treatment, if we get as far as needing immunotherapy, that is training their body out of the allergy, in children's age groups, we have an under-the-tongue treatment, which they take every day. But with the adults, it's more common to do that by injection therapy, where they have a series of injections per year, which is just as effective, but actually obviously needs more visits and isn't as comfortable. So there are some changes in terms of the treatment. And then the other thing to say is that a lot of the changes with age relates to the likelihood of drug allergy. So with antibiotic allergy and potentially allergies to other medicines as well, that gets more likely as people get older through their age groups. And that's both because of the exposure, you're exposed to more medicines, but also as children go through to adulthood and then into older age groups, they get more vulnerable to other disorders, meaning that they're less likely to be as stable and able to cope with an allergic reaction. So the levels of drug allergy go up in adults gradually, and it gets harder to work out whether or not they're allergic or not, because they may be unwell anyway, and therefore difficult to undertake the testing. And we don't have so much of a prevalence or likelihood of medicine allergy in children.
Oh, right. Well, it's interesting, isn't it? And why? I was going to say, this is very much a random question. As you get older, you seem to, more and more things seem to go wrong, don't they?
Well, most of the allergies, you have to be exposed to something before your immune system can learn to be allergic to it. And part of it is just that the amount of support that you need from antibiotics and medicines as you get older means you're more likely to have that exposure. So part of it is with time, you're more likely to pick these things up. But actually, when it comes down to the foods, the likely food allergies around in childhood normally reflect the diet of what is commonly in the diet for that country. So we have plenty of milk, egg and nut allergies. In other countries, such as the Far East, where they eat lots of seafood, they see their seafood allergies amongst children as well, whereas we tend to see them later on, and it's normally seafood allergy is more common amongst adults than it is among children. So it does depend upon the environment and how often you're exposed to these things. And
is that because children don't eat fish or seafood as much when they're younger?
In our country, they tend to have finfish quite a lot. So the swimming finfish is something that you can pick up as an allergy, and that's not a common allergy, but it's one of the major groups. But when it comes to shellfish, so crustaceans and prawns and lobster and crab and squid and so on, those are more common in those coastal countries. So particularly thinking about Thailand and around certain areas of China and the Far East, it's more common for children to be weaning onto prawns and shrimps and so on when they're young. And that tends to be more common as a food allergy in those countries.
Right. Oh, so what we're going to cover today is, because I know it's sort of all quite a complex thing, because one thing runs into another, because with Talk Health Heritage, we started off with Talk Eczema and then realised that allergies were very akin to eczema and respiratory. And so I know they're very interlinked, and it's very hard to know if it's an allergy or it's eczema. But I think you've suggested that we start off with a baseline of talking about eczema, and from there start exploring how we then move into allergy issues and respiratory issues.
Yeah, exactly. And there's a very good reason for that. So when I joined to do the studies to protect against food allergy, we knew that we wanted to start looking at a younger age group of babies, because even their skin barrier and their skin at the age of 3 months predicted what would later happen with food allergies. And the reason is that the body develops the skin, and in skin that's healthy, it also has a waterproofing protein that it uses to shield the skin and protect it. Unfortunately, in about 10% of the whole population of the UK, there is a damaged gene for that. So it's a filaggrin mutation, and it means that your skin is less waterproof and becomes more dry. That makes it more likely that young babies develop eczema, and it's when you've got this eczema condition that sometimes flares and gets infected on its own, that is more likely that you then pick up the food allergies, which you're exposed to from food in your household environment, that then builds towards what may be a food allergy over the first few years of life.
Oh, wow.
So a lot of it starts with eczema. And unfortunately, in the olden days, we used to say avoid absolutely everything. And now we know that if you introduce the foods proactively, you can protect against food allergies. But you have to look quite early, and you have to look in infancy to see that process emerging, because normally the eczema emerges first, and then it's shortly followed by some children then also picking up these food allergies.
So when does it first present? I mean, I know eczema presents, at a very early stage for children or babies.
It can do. Yeah, it can do. I mean, so even at 3 to 4 months of age, we find that there is at least a quarter of babies who have some sign, even if it's subtle, some sign of eczema. So it is quite early. And then we only really see the worries about the food allergies with reactions by the time they're later given these foods to eat. So with milk, there's more of a concern early on, because clearly there are some mums that aren't able to breastfeed or have top-ups because of concerns with weight, where they're introduced to cow's milk formula. And so cow's milk we tend to see emerging as a concern earlier in infancy. And it's normally later on that we realize that these babies who are growing into toddlers may have tried egg and they may have egg allergy, or it used to be a concern when they're over the age of 1 or 2 that they may develop peanut allergy. But in those children where they already had quite severe or undertreated eczema when they were young babies, they may have already developed the peanut allergy from the peanuts in their household environment when they were tiny. It's just that we didn't see any problem with it until we then later tried to give them peanut butter. And of course, one of the difficulties now is about trying to choose a safe approach for introducing the food safely to babies who have eczema when they're younger.
So, you know, you hear about, or one hears about things that when you're pregnant, if I had, people say, I had too many nuts, that has caused a problem. I mean, is that true, or? So
there have been studies looking at whether or not when pregnant mums eat plenty of nuts, whether it's a good thing or whether it's a bad thing. And they tend to show different results in different studies. And the reason is because we're not necessarily measuring the most important thing. Everyone assumes that what goes in for the maternal diet is going to be pivotal because it's got to be shared with the nutrition for the baby, whether or not the baby's inside or whether the baby's breastfeeding. And that is true. But the amounts of protein from the whole foods that comes through in breast milk is ever so low. So it's been measured for cow's milk, for example, that even if a mum drinks a whole pint of fresh cow's milk, the most that a baby can get in one complete breastfeed is 0.01 milligrams, right? And that's milligrams. So we're talking 0.0001 gram. We're talking a tiny amount. You know, you certainly haven't got a chance of seeing it.
Yeah.
So because that amount is very small, it raises the question that maybe some babies who are very sensitive could possibly have a change in symptoms according to their maternal diet. But what is also happening, particularly when mums have plenty of nuts through their pregnancy and when their child is young, is that they're often having it as dry nuts as a snack because breastfeeding is a high energy business. And so you need to keep your energy up with these youngsters. And often it means that there's more nuts being shed into the environment and around the young baby and around the young baby's skin and around their eczema. And we now know from studies that actually it's the impacts of these nuts directly on the baby's skin that may be a route of sensitization and developing nut allergies. So it's not necessarily the process of eating it directly. No. It's probably actually all about the environment and how we manage those nuts and how the baby's skin is exposed to it.
So is that, and that would be that they're prone to it because they haven't got they're not waterproofed enough, or?
Yes, completely. Yeah. Completely. So, and that actually goes to one of the most important principles about how to manage eczema. When you've got eczema, it's really sensitive skin, both because it's more likely to be dry, it's more likely to have a problem with waterproofing, and it's probably got some underlying itchy inflammation in there anyway. And so that makes it very susceptible to the environment. We just spoken about the process of having food allergens in the environment and then that impacting on the skin and sensitization. But you're right, in the same way that if you haven't got a waterproof coat, you get everything soaking in, right? You get the rainwater soaking, you can get inflammation with soaps that are more obvious. You can have contact problems with, if you're using woolen cloths and synthetic garments. Overheating is often a problem. Starting to wean with strawberries and tomatoes, which are a bit acidic, can give you a local contact skin rash. And that's all the impacts of dealing with a sensitive skin barrier. They're not all related to allergies, but a lot of people worry, is this an allergy to tomato? Is this a problem with red pepper? That would be astoundingly unlikely, but it might make the skin go red and itchy and sore.
So when people have we're starting with children and they feel their child's got eczema, is it natural to think that it is an allergy that has caused the eczema, or is it just eczema itself, if that makes sense?
So when we're talking about the allergies when we're talking about the eczema first starting, it starts as a skin barrier problem. And there isn't necessarily any allergy there at all. And we know that just having the eczema and sometimes a different type of skin bug, it's called Staphylococcus, is more likely to make that infected, and that can become incredibly sore and angry. And you don't need to have any allergy for that. Eczema anyway has a waxing and waning progression where it comes and goes and comes and goes. So it really means that, exactly as you say, parents are out there on the lookout. Well, what could it be? It must be something that I've eaten, or something in the washing up liquid, or something. But actually, it can just be the waxing and waning of the skin barrier itself and other things that you don't see. So, for example, whenever young children have snotty noses and sore throats, it really activates the immune system, and you can get terrible rashes with a lot of the common viruses that are passed around. And that's often a breakout reason for children who've got sensitive skin and a likelihood to eczema. And that's nothing to do with allergens at all. And I think that's part of the difficulty, is that you can't see what's driving this eczema. And of course, parents feel very responsible. What can I possibly do? And so they want to change the washing powder. They want to change what's in their own diet as a way of trying to manage something, because this is happening day in, day out. It might mean their children can't go out, can't go to nursery. Their grandparents see them looking uncomfortable. They're not able to sleep. It can be very, very difficult to deal with angry eczema. And also, parents feel guilty about, do they need to use different types of creams? And it means that they feel worried about using creams that might need to be prescribed, or whether they should use a natural cream. And that's another whole discussion in itself. But we shouldn't assume that it's down to an allergy initially. And one of the most important steps is to try to use the creams that are sensible as a first step to solve it, because eczema normally starts as a skin barrier problem. It doesn't normally start because of an allergy.
All right. Okay. So what you're saying is, with the eczema, you first of all just try to understand how to manage the eczema. Actually, I can see lots of questions kind of coming in, and I think they're going into chat and into the Q&A. So if I could ask people to put the comments into the Q&A, that would be helpful, because it all gets a bit too confusing for me. And
where's the Q&A? How does that work?
Well, don't you worry about that. I'm looking. When I put my glasses on, you know that I'll start reading.
Then it's serious. Okay.
That's the cue. So yeah. So I can't remember what I was saying then before. What was I saying about the eczema? So the first thing is to look at if it's just a skin problem. So that's what your baseline is, understanding if it's just a skin problem, and then from that you're looking at treating it with various, I suppose, wet wraps, or whatever they're called.
Just standard skincare treatments are a good place to start. If it's just mild eczema, it may just be there because the skin is dry, and it might simply need moisturizing to help alleviate that as a barrier problem, and the eczema might gradually subside. And that's certainly common practice amongst the GPs. But it gets more difficult when it gets actively itchy, because there's some inflammation behind this, which is making it so sore that little ones are scratching. And if that happens, you normally need some form of anti-itch medicine, some form of prescribed cream, in order to get over it. Now, if you want the mildest one, you can just buy some of these over the counter. And if you've got a little one who's over 1 year of age, or I think it's over 2, you can just buy hydrocortisone, which is perfectly good to start off with. And it's super, super safe. I mean, I've never heard of anyone having a side effect with hydrocortisone. There are 4 different strengths of these creams, and the top one is only dealt with by dermatologists. The next one down is one that we do use in more serious eczema. And then there's the middle one, which is called clobetasone or Umivate, and that strength is really helpful because it can solve most eczema without leaving it so long that you've got the ongoing concerns about the food, about the washing, about the clothes, about the routines, about sunlight, about preservatives, about everything, right? And it can really be a sensible level to check, because they've done studies to see that even the strength above doesn't give you significant side effects. I just did a review in the BMJ last year to show there's no significant difference in 2 randomized trials of the stage 3 mometasone, comparing that to a normal standard skin cream. So if that doesn't give you side effects, in young children, taking a step down makes lots of sense. And actually that's good therapy for the skin barrier when it's itchy. And if we were more comfortable using that, then it would get a lot easier to be able to see, well, is this just a skin barrier thing? Or do we have to think about solving other things as well and looking for allergies and looking for other problems before we know whether that's really driving it? We should probably just try and sort the skin properly first.
So obviously you mentioned a dermatologist, and would you call yourself an allergist?
An allergist. So I'm an allergist, but actually we're all trained in pediatrics as well. And one of the nice things about doing the specialist clinic, which is with the gastroenterology and with the pediatric allergy, is a lot of it is general childhood illnesses. So there's issues with tummy pain and constipation and vomiting and whatever all the other general pediatric issues are, which we're all happy to deal with, because certainly when it comes to allergy and general pediatrics, a lot of those problems interrelate with each other.
So if a child presents with eczema, and the doctor can't clear it, would they? At which point do they'd send them, I presume, to a dermatologist first? And at which point would you become involved, or would you become involved at that point because of the child's age?
So that's a really good question. Part of it is down to what the possible triggers might be. And one of the things that's difficult is that with children with eczema, trying to make them have the safest environment, you end up trying a number of different factors just to get them to the point where they can sleep often. And by then, you realise you've tried a bit of lots of different approaches. And if that's the case, they may well be avoiding foods when they don't need to. So even though there's not a clear one-off trigger, it's still quite helpful to have at least an allergy test to completely rule out that this is a problem. And then we're in the position where we can say, look, we can do the appropriate tests. We can reassure you it's not an issue. You can put it safely back in your child's diet. And then we can monitor that process and make sure that that goes well. So that really means that you increase quality of life because you can normalize so many more things. Avoiding foods that may be in lots of different ingredients is difficult. So that's one of the key factors. It's about asking for the right person at the start of the journey to say, look, I've got concerns about these, if there's a need to be, being frank with that and trying to involve that in the pathway. There aren't very many dermatologists who are completely happy with doing allergy blood tests. Some of them do, but some of them find that it all gets tricky quite quickly. And so we are in quite a privileged position to be able to sort out problems when they present, both with the eczema side of things and also to try and help rule out those allergies if that is a concern. But also we can look for other things as well. So one of the things that we'll come on to is, well, actually a lot of the children where the parents really notice the eczema, they may also have hay fever or coughs or colds which seem to grumble along a long time, and they might also be having other conditions like asthma underlying.
So hopefully I've got a child, got a problem, and I've managed to speak to my doctor, understands the difference between a dermatologist and somebody like you, and hopefully we have access to you. You've then realised that actually we've tried everything with the skin, but there is still an issue. So that obviously then leads you on to there's an allergen issue.
And that is a possibility. There's basically three types of, if we just take food for the moment, there's three different types of responses. There's those responses which everyone knows as a clear allergy, an immediate allergy, where you can measure the antibodies, and it has to be IgE antibodies to define as an immediate allergy. So common allergies would be nut allergies, or egg is quite common in eczema that's difficult to get under control. A lot of children might have cakes and pancakes and they're happy having Yorkshire puddings and so on. It may possibly be flaring their eczema, even though it's an immediate allergy. So that's one thing to get right. There are also the non-IgE allergies, and that's normally for young babies. Once they're at school, it's vanishingly rare to have children that still have problems with their eczema because of milk, for example. And then there are the irritant responses that we discussed before, which is about the soreness on the skin and the contact. There are those three main groups. But you can have immediate allergies to pollens, to house dust mites, and that can also aggravate and give you flares in the eczema as well. But we need to do diagnostic tests with those, with the right type of blood tests rather than high street tests, to try to get the right diagnosis first before we know how sure we are it is an allergy and what may make a difference.
So what's the difference? So, I mean, you do hear about all these people that run tests, and I know that it's quite a contentious issue, and I certainly know it was a few years ago, and I presume is that still the case with the high street shops saying, come in here, we can do a blood test, we can diagnose what you're allergic to. And
yeah, it's a huge issue. And if you do surveys, and I think it was a survey done from a dermatology department, I think it was in Bath, where they were saying, what's all the tests that you've really had? And the proportions, there's a fifth of patients with troublesome skin disorders who have been to look on the internet, to see what they can get down the allergy fair, to, just see what they can access. And a lot of them are promoted as important services that not many people can reach or find out about. But there are some real important quality steps in with these. Anything that involves anything other than a blood test from a high street point of view is likely not to be helpful. So, for example, if there's a hair test where you pluck a piece of hair, or there's Vega testing where you hold a certain fruit and then you measure with the angle of your hand, and there's some Van de Graaff sparking generator thing in the corner. And there are some pretty wacky tests out there. Any of these measuring electrical currents and so on, these have no evidence at all. So if it looks a bit unusual, it probably isn't going to give you good advice. And certainly when you're dealing with your health, it's worth sticking to what is really sensible and really evidence-based. The other type, which is a blood test to steer clear of, are the York tests, and they measure IgG. So that's a normal antibody that you produce after you've had an infection, but they're measuring it to food. And actually what they're measuring then is how much of the food you've been eating. So it's really quite common if you have an IgG test, a York test, for it comes back giving you all the foods that you're eating regularly. That's because it's measuring your diet. It's not really measuring the allergy antibody part of the immune response. So it can be really confusing. It often comes back saying yeast and wheat and all of these foods that are pretty unlikely to cause an immediate allergy. So we really have to be careful with seeking these tests, that we're talking about IgE and that we're thinking about bloods only for IgE. There are some new tests which have come out recently where they do panel testing to either 112 or over 200 allergens, and that's offers from some pharmacy. Now, the tests themselves, the actual test procedure is accurate enough, but the problem is that because you're testing 200 things at once, something's going to come up positive in the majority of people, even though it's innocuous. I mean, the statistical definition of chance is 5%. So if you've got 200 allergens, you're definitely going to come up with a good 10 which are going to be lit up positive, and it isn't down to necessarily anything more than chance. So it gets difficult to read, and that's where it's really important to have someone go through these results, unpick the history to work out, well, what should we really be looking at within this range of values, and then seeing whether that matches up with the kind of symptoms that we're being reported and describing for adulthood or for childhood.
And so with the, let's say you've done, so well, the first thing to note then, obviously it's really important to make sure you get the right testing. You understand the testing you've had, you understand the results that you've had. And I presume particularly in children, it's important because, the whole point is that you build up, as you said, because I'm sure you're going to talk a bit later about how you build up people's immune system. So if you take something away, then they've got even less immunity.
Exactly. So you're not going to necessarily tolerate that for a long time. And that was one of the problems before, when there was eczema, they were said to maybe have allergies. So avoid everything. You avoid milk and egg and fish and wheat and nuts and sesame. I mean, the body then has to wait a long time before it can learn to tolerate these things via the good routes, by eating it orally. So you're completely right that actually just general avoidance is a problem. Avoiding things that are unlikely to be an allergen. I mean, a lot of the fruit and veg don't have a lot of protein in them. So often we're brought up with a target of bringing up children about they need to be having lots of broccoli and Brussels sprouts and lots of different fruit and veg. And that's fine. But if certain fruit don't agree with them because it's acidic and makes their skin irritated, they're not going to miss out by not having that regularly in their diets, in the same way that they would miss out if they weren't having any milk or any egg. Not only is it not as a widespread ingredient, but nutritionally it's less important, and it's less likely to develop into a longer term allergy from those fruits and veg. So it's about prioritizing which are the most important foods to get in as well.
And so once you found what you believe might be the issue through blood tests, you then you do a program to introduce it into a child's or an adult's diet?
Yeah, exactly. So there's the blood tests are most easily accessed because they can be ordered by your GP. If you want to have a allergy test done with someone who's got skin prick testing, you can get these results rather than waiting for a blood result coming on a piece of paper. You can do skin testing on your arm to see whether it shows up as an allergy bump and whether or not it's a possible allergy to each of these foods as well. And that's an equally valid way of getting important allergy test results. For that test, though, you need to avoid antihistamine for 5 days. So it won't come up with any allergy bumps if you're on the antihistamine treatment. So after those 2 types of sensitization tests, you can then look back and say, well, look, if all of them are negative, then it sounds like it's really safe to introduce into the diet. If some of them are high to the level where they're above the 95% positive predictive value, it's very likely an allergy. So very high, very low. And then you've got this mid-range where you've got to decide what to do with these values. Is this an important food that otherwise the patient or the family or the adult would like to introduce? Is it something that by avoiding it, it's causing a lot of distress and uncertainty, and it's potentially unsafe if they have it by accident? And to get greater clarity where we know there is a risk of an immediate allergy, we would normally do a food challenge in hospital if it's important to take that step. And it's as a procedure, we do consent beforehand to make sure the patient knows what would happen if they would have a mild allergic reaction or a more serious breathing and throat cough or drowsiness reaction, which is all part of anaphylaxis. And then we would go through the process of giving them the food under supervision. If that's what's indicated, if otherwise they would eat that in their diet, and it's important to really find out. But we would hope that for the majority of people who have got negative tests, that it's fine to do that at home because the likelihood of having an allergic reaction is ever so small. But it would be important to give a way of doing that and targets for amounts and how to do that safely.
So moving on then to the other things is that obviously we spoke about food allergens, but there's obviously other things which are sort of dust mites and all the other creepy kind of crawlies. And does that then move into the respiratory side as well?
Exactly. Yeah, completely. So when you eat a food allergen, you can get some respiratory signs because you absorb it into your bloodstream. So it can be a systemic response and can give you wheeze and sneezing and itching of the nose. But with the environmental allergies, they are things that you breathe in. Yeah, they're ones that you either breathe in and you might get wheeze. You might have a problem with having a runny nose or itchy eyes. And those are more of the allergic characteristics. So, you know, the kind of hay fever when it comes in those pollen seasons, but you can get dust mite allergic rhinitis throughout the whole year. And it's quite common for people just to think they've got a constant nasal cold and they don't know why it won't go away, or that their child is always sniffing and rubbing their nose and itching. Some children go to bed at night and have a regular nosebleed because they're rubbing their nose so hard in their sleep that it really is aggravating them. And because it's over such a long period of time, people don't step back and go, well, hang on, there's no reason why this is such a problem. Why is this going on? This is unusual. And normally a straightforward test to house dust mites, as you say, or pets, if they live with pets, pollens, it's fairly easy to read those results and see the degree of likelihood of having that as an allergy as well.
And then and the positive things for children is that a lot of children grow out of eczema and allergies just purely as a time thing, isn't it? But
right.
That's obviously not always the case for adults. And I suppose, and then for adults, is it the case that sometimes they grow out of an allergy and as they get older, that allergy comes back again?
It can do. there seems to be a period of life where it's sort of around mid-adulthood where it's more of a problem to get hay fever, and it does sometimes subside as people go more into the older age group. But there's lots of exposure factors to consider when you seem to get a bad season and then a good season. People's lifestyles change. There's more people cycling now and having more time outdoors because we've realized it's a release to do that. So exposure like that makes a difference, but not all the same plants and trees flower and have pollen in the same seasons to the same extent every year. That also changes.
Have you got a problem?
No, this is just a cough. I'm just going. It's all fine. No, it's good.
Okay. I'm aware that there's quite a lot of comments and everything to go through and questions. So I just wondered, if there's anything that you wanted to wrap up about what we've said. I know we haven't done very much about, how to help yourself, but I think obviously helping yourself is actually making sure you get the right test, understand what it is, and then look at the ways to hopefully try to reintroduce it if it's necessary, or if it's not. It depends how important it is in the chain of things, I suppose.
Yeah, exactly. And I think going to the right person for the right advice is a really important part of that. It's probably also worth saying that in combination with the breathing allergies, there is the other signs of asthma, which is always worth looking out for. Asthma is very common. It's about 12% of children who go to school have asthma. And the signs of that can be very easy to miss as well. But if your child is coughing in the evenings, even when they don't have a viral illness, if they have a problem where they cough or they catch their breath going into cold air, especially if they're doing sport outside, those are good signs that there may be twitchy airways where their asthma is getting tight and making it harder for them to breathe when they otherwise might not notice it either. So there are some signs to look out with. If you have allergic asthma, it's more obvious that it comes on at a time when you've just gone onto an Airbnb and there's lots of cushions and there's dust in a holiday home, or in the pollen season where they've been rolling down cut grass banks and then they seem to get wheezy, scratchy and itchy. But sometimes it's these regular assumptions that my child just tends to cough in the evening, that's normal, that we should look at in a bit more detail. Because when you ask them, well, how is it when you run around at PE at school, when as parents we never see them, actually they might be able to tell you something that's quite important at that stage. I think that's a really important message.
Okay, right. So what I will do, because I'm obviously going to get confused now, so I've got a few things. If I start off with some of the questions that were sent in to us to start with, when people registered, and then hopefully we've got 20 minutes to whiz through everything. I have sleep apnea and eczema mainly in the past. I've tried dairy-free and currently mainly lactose-free. I still get blocked, sore sinuses, coconut oil helps. Any suggestions, please?
Mm-hmm. So if it's an airway problem, it's unlikely to respond to milk management or lactose-free management itself. So because lactose, lactating and milk, it all gets confused. Lactose is a sugar. And so you can't have an allergy to a sugar, it has to be an allergy to a protein. And the signs of lactose intolerance are always bloating, tummy pain and diarrhea. So lactose itself can't cause eczema. And it can't cause vomiting either. And that's something which is difficult for the message to get out there, because lots of people try lots of different things and it all gets confusing, as in this case. I think that with breathing difficulty at night and with eczema, it may be that dust allergy has got an impact on both because of the nasal congestion, because of the feeling of not being able to breathe clearly. And you can have dust mite asthma as well, making it difficult to breathe. If it's predominantly a snoring problem whereby the snoring actually wakes you up regularly, then there can be other anatomical airway problems, and it's important to get that reviewed in hospital. This sounds like an adult speaking, and I would have to say there's a whole bunch of issues where that needs an assessment by someone who can actually examine you and have a proper look. But eczema in this age group is much more likely to be down to house dust mite allergy than something like, certainly not lactose in the diet. And I'd be very surprised if it was milk related really. And I'd want to make sure that you're having good standard steroids, creams and ointments to see whether that solves the eczema before then considering other allergy tests and potentially house dust mite allergy tests to look at that further.
Okay. What causes, I think this must be an adult too, what causes allergies, sensitivities in ME/CFS, and what can be done to dampen down the symptoms when avoidance is so extensive?
Okay, in CFS, and what was the other one?
ME, so the same thing, chronic fatigue.
Yeah, chronic fatigue. So to my knowledge, there's no evidence suggesting that diet has got a clear role to play in chronic fatigue syndrome. And that's all I'm going to say about that. I think that there's fantastic fatigue services which are quite specialist in different parts of the country. I know about, there's the UCL one from a London point of view, there's a Bath University one as well, which is very well regarded. And the position of diet in that is really very uncertain. So I can't say any more than that. It's outside my expertise.
Okay. Now, I appear to suffer from food allergies or intolerance, really, but have failed to get to the root of these. Sometimes I get flushes, itching skin, and flare of eczema. I'm also very sensitive to smell. Some affect me severely and impact my eyes, thinking, and cognitive ability. But again, cannot see a link or pattern in ingredients. I went for what I thought was testing a couple of years back, and it turned out to be a bioresonance feedback, and I was told I had a yeast imbalance.
So this is one of the tests I was talking about, where it's very difficult to work out what's going on. And the bioresonance is one of these electric circuits.
Right.
Tests. So I think it's very difficult in that to make sense out of what those readouts will be. And it's probably better to start off with the other general problems afresh. What were the symptoms and the troubles?
Well, the major thing really is fibromyalgia. Then I say she, I don't know if it's a lady, sorry.
Yeah.
The person says that, so then actually her fibromyalgia did help. We get better while she was doing a yeast detox. So I think basically she's asking, should she come off yeast? But I think, maybe the thing is to go back and have a proper test, not, when I say a proper test, to have an evidence-based test.
I think you're right. I think it's a really difficult area with fatigue, and there are so many things that impact upon it. One of the approaches that's shown the best ways of making progress is about a sort of rehabilitative lifestyle approach. But as for how to tailor that to different particular people and for adults with different other issues and concerns, I really am not in a good position to discuss that.
Okay, so there was also the other one I think that we sent to you before. Interested to hear about a trial or get prescribed.
So dupilumab is one of these new monoclonal antibody treatments. So it's trying to treat one of the antibodies that may be driving the inflammation of eczema. And it's a series of injections, and it has had outstanding results in research. It's starting to come online in some of the specialist hospitals. And certainly in the children's age group, you need to have had a prolonged go with trying to do this, at least this third level of steroids, and finding that still doesn't have an impact before then it becomes a possible option to be funded through the NHS. So there are quite strict criteria under how to access that, and you need to do the game of going through all of the conventional treatments with the dermatology teams before you then become eligible. And it does get funded, not hugely widely at the moment, because you need to do it to centres who are used to the process of having it come through. But at St Thomas's, we're getting an increasing number of people coming through for dupilumab treatment, which is the antibody treatment. So there are even possible uses and trials in research of using dupilumab at a younger age group, but those are just being designed at the moment, and we don't know that those are going to go ahead. So I think the only way to access that at the moment is by going through NHS dermatologists in a large centre where they've got a service that delivers it, to be able to see whether the management and progressing with management means that you are eligible or not.
Okay, right. I'm now going on to the Q&A session. So this may clash with the chat as well. I'm not sure, but anyway, I'll just go through this. So somebody says, thank you very much for doing this for kids. I think it's vital to get things under control early. I'm convinced a lot of my problems stem from no allergies being diagnosed, poor eczema due to allergies, but this is just treated with topical steroids. Can you discuss how and when you prescribe topical steroids? At what age should they be prescribed? I'm anxious to get awareness about topical steroid withdrawal in later life when topical steroids can be avoided early.
Okay. So topical steroids are safe according to which of the levels that we're choosing, and it's most widely available at the first level, which is hydrocortisone, and there are no known side effects with hydrocortisone. You can use it liberally and it should be absolutely fine. Even with the strength one up from that, I've only ever heard of one person who had what sounds like could possibly be a side effect with that strength, and that was after it was used indiscriminately. So really, it is safe to use these two levels, so the hydrocortisone and the next step up, which is called moderate topical corticosteroid. As for the concerns whereby you try to get through without it, I think that's difficult, because certainly I worry that undertreated eczema means that you have a more prolonged period whereby that you can pick up other allergies, such as food allergies, through the eczema on the skin. And that's something where they're doing a study at the moment in Japan to see whether the opposite is true, whether by using hydrocortisone early can protect against food allergy by trying to switch off the eczema when it first appears.
Okay, can you test for filaggrin mutation?
So that's what we do in the research studies. It's not available as a test for clinical practice. You need to go through the research labs to get that, but there is a trick. The trick is this. So if you look at this part of your hand, right, which is down here, it shouldn't have many creases on it because you don't have a joint there, right? All of this moves together. It's the hypophenar eminence, the bottom of your thumb, all right? If you look at it there and you see how liney it is, it gives you an idea about how dry your skin is. What they showed is that if it looks like the cheek of a beautiful baby in a photo, you're fine. If it looks a bit liney, then you may have a waterproofing issue. But actually, if you've got double crisscrosses where it looks like it's skin that's a bit dry and has taken a whacking, it's a good area to look and see whether you may have one of these filaggrin mutations. And in fact, if you've got very wrinkled and creased and linear lines over the skin there, it's more likely that you've got 2 copies of the mutation for filaggrin. So that's probably the easiest way of assessing how dry your skin is, apart from what you generally feel yourself. But there isn't any availability to have that on the NHS as part of normal practice. Right.
My son has atopic eczema since he was a baby. I breastfed for 1 year. I breastfed for 1 year after. Oops, sorry. I breastfed for 1 year after, and it stopped his allergy after his allergy was discovered. He's now 15, has been patch tested, and is allergic to propylene, which is in everything. He has only slept for 4 hours every night. The doctor wouldn't give him anything, even melatonin. I research everything, gradually it's got better. He is lactose intolerant and manages small dairy now. Recently, he's got an allergy to the glue in his shoes. Given the cost, is there any help available? I also have an underactive thyroid. Would have this contributed to his getting this condition? I have done wet wrapping. Antihistamines make him sleep. He is also allergic to cream and has to have oil.
Okay.
So it's quite a lot there.
Yeah, no, there's lots of different involved issues. I don't do patch testing. So patch testing is different to skin prick testing. Skin prick testing, you put little drops of the allergens on and you introduce it into the top layer of the skin, and 15 minutes later you look for an allergy wheel. Patch testing is where you look for individual small chemicals, which are in things like cosmetics and creams. And you put them in little bubbles that you then fix to the back. You leave the bubbles there for 3 days, you take them off, and then 3 days later you read the result to see how much redness and inflammation is in the positions where these different skin cream ingredients are. Now, the reading of those is very complicated, and it needs to be read by specialist dermatologists who are used to patch testing. And the reason is that with some sensitive skin types, you have some redness reactions coming up, even though it's not a specific allergy to that individual chemical. There's a certain pattern of standard erythema whereby that's just the process of doing it, and because these skin creams have a tendency to irritate. So I wouldn't know from where I'm sitting now about the relevance specifically of propylene, and I don't want to make any judgments as for what kind of likelihood of a difficult allergy or difficult avoidance that is, because it's not my area at all. But I'm glad that patch testing has been done if that's appropriate for what the situation was at the time, because it's quite a specialist test to do. In terms of the degree of eczema, again, it's something whereby, according to examination, according to following through the whole picture of what's being tried before in different treatments, you have to problem solve according to how it is at the time. There are potentially some circumstances whereby if you live at home with a cat and no one's thought about cat allergy, and that might also be driving the eczema, then there are other reasons for considering allergies alongside it. So if sneezing, itchiness, and feeling like you've got itchy eyes is a constant problem as part of the eczema, then potentially there's an allergy driver from an environmental point of view. The lactose was mentioned. Again, lactose can only give you tummy pain, diarrhea, and bloating. It can't give you eczema. So lactose, and you mentioned growing out of milk, I think that it's a good time to start reintroducing milk generally. If it was always a delayed allergy associated with eczema when younger, it shouldn't be there for older children and for adults. And thyroid. So thyroid is normally a different part of the immune system to the allergy type part of the immune system, which drives eczema. So it would be unlikely that thyroid has got an issue as far as I know, but there's more thyroid problems in adults than there are in children. So potentially that's an association to ask about with adult doctors rather than from my understanding.
All right. Now there's a few, one of our members who is one of our great friends is very pro or has an issue, as we've discussed, about tropical steroid withdrawal, and
okay.
she's just very, very keen to raise awareness and for people to for more clinicians to go and understand what the issues are and how it can be improved. And she was just saying that I've heard of people now being in topical steroid withdrawal from using just hydrocortisone. It's not safe for long-term use and should only be recommended with advice about how long to use it. Please can we research more on topical steroid? I think also a lot of it, if people do abuse, they might say they've used things, but there's that abuse as well, isn't there?
It's a difficult area because we and you're quite right, we really do need more studies to understand more of what's going on. So the medical name for it is tachyphylaxis, which is with prolonged use, it can cause its own problems. So it has got its own thinking and its own considerations. But in terms of studies that prove that that is an issue, where it's enough of a significant problem to warn people of preemptively, I haven't seen those kind of studies. So I think I mentioned the study on the side effects from eczema treatments, and there are these 2 randomized trials. It's got 200 people in them, but 200 isn't very many. If you compare that to the number of people with eczema, it's a tiny number of patients to be able to study side effects properly. And I think there is a real need to get some proper good quality research on it for the reasons that you outlined.
But I mean, there are loads of questions that are sort of coming in, and I'm sort of concerned we're not going. I think you've answered them. Does sugar trigger eczema?
Sugar doesn't trigger eczema. With the foods that sugar often is associated with, it can be in other ingredients and other foods that might lead to other changes. So I'm not just thinking about allergies. There was a professor who was desperate to prove that preservative allergy doesn't exist. And so he joined a trial to have industrial doses of preservatives just to prove that he wouldn't be unwell. And he was really unwell. So some of the old-fashioned preservatives can have an impact on how angry skin is. And I know from my own point of view, my own skin, I can read on the back of an ingredients, contains only natural, rhubarb juice and beetroot flavors, and it's tangy and tasty and what have you. I still get really itchy 12 hours after having these things that are completely natural. So I don't think it's the sugar. I think it's more likely that there are other things that we still don't understand, which are strong irritants within these foods that often aren't natural, right? They're not normally just the fruits and standard things that you can buy fresh. Normally it's something that's heavily processed and it's got fancy colors in it, even if they purport to be natural colors. And some of them still drive me mad, even though I don't know what's in them either. So I think we just have to respect that the more processed and the more unusual tangtastic type foods may well just drive eczema from an irritant point of view.
When you talk about tests, do you mean scratch tests? What do you think about LGE blood tests? Are they useful?
So yes, the LGE is it's a capital IgE. So those are the immunoglobulin. So that's the immunoglobulin E tests. So they are fabulously useful. We use them all the time in clinical practice. I've ordered 10 sets already today. They are the bread and butter. So scratch tests is the old-fashioned name for skin prick tests. We're talking about the same thing where you have allergen by allergen. In the olden days when they first designed it, they used to make a little scratch mark, and now we know that you just need to touch it so it's more comfortable. But that's it. Those are the sensitization tests, which are the gold standard for supporting an allergy diagnosis. Yes.
Right. So, and yes, I remember we talked about them.
Yeah, they're also called RAST tests. There was a different way of doing them in the lab. And so a lot of the GP practices talk about RAST. It's an abbreviation with capital RAST. That is also the same gold standard sensitization test, which is to be trusted.
Right. And I will just finish off on one last question I've got here, and I'm sorry that I haven't got through to look at the chat. Do you also deal with environmental allergies causing chronic coughing and phlegm? No consultant seems to be able to find out exactly what I have and what can be done and how it can be improved. Because obviously you were talking about the coughing earlier.
Yeah. So that sounds like that's an adult asking the question.
Yeah.
I think it's difficult because it sounds like you've already had medical advice, and then in your particular case, there's reasons to further consider it. I think it's really difficult for me to comment, really, both because it's in adulthood. There are other interrelated respiratory disorders, and I can't really comment on that without actually seeing and evaluating. Principally with an adult colleague who'd be able to take the lead on that, I'm afraid.
Okay, right. I've shut the chat down now, I'm afraid, everybody. It's too much. But yeah, but there were thank yous in there from people, particularly our TSW, our topical steroid withdrawal fan, for want of a better word.
Good. Well, look, we all need more engagement, more discussions to have these kind of opportunities to speak directly, because I mean, you're raising really important issues, and it is about trying to make it work so that it does work as a whole for people's in their lives. So no, it's great to have the opportunity, and thank you.
No, and thank you very much. It's been really, really interesting, and yes, and I hope we get to speak to you again in the not too distant future. Excellent. Thank you very much, Tom. Thank you, everybody. Bye.
All the very best. Nice to meet you. Bye-bye.